medicine. He is well published, including a publication which is Bad Medicine, and co-authored a book with Dr. Tripachi on hereditary and connective tissue disorders. So Dr. Soloway, um, um,
Let me put this here. Okay, well, thank you for having me. Thank you, Dr. Ralph-Lugani and Dr. DePachi and Dr. Cunanan. Anyone else I forgot? Dr. Colombo. Anyone else? Anyway, so I don't have any slides, and I'm going to do this like I often do and kind of wing it, but hopefully I can follow up on Dr. DePachi and Dr. Cunanan and lead into Dr. Colombo. So they asked me to focus a little bit on fibromyalgia and how fibromyalgia relates here. So in reality, I don't really think, well, fibromyalgia has a definition. The definition of fibromyalgia is trigger points above and below the diaphragm, bilateral, for more than 6 months. 5 out of 10 people a day come into my office and they just say, I hurt all over. I hurt all over, and they have brain fog, they have dizziness, they have palpitations, they have sprained ankles, they have dislocated hips, they have stretchy skin, they have striae or stretch marks, they have pysogenic papules, which I have a picture of in the phone that I will share with you. They have literally everything. So the people that come with fibromyalgia, 100% of them do not. I've never seen a case of fibromyalgia by the definition that fibromyalgia carries in the rheumatology literature. And of course, it's one of the most common diagnosed problems in rheumatology. And I really believe at this point, after 35 years of rheumatology, I believe that diagnosis is wrong. And fibromyalgia needs to be reclassified as a distinct pain syndrome, a regional pain syndrome, or a non-regional pain syndrome. But hypermobility, see, I like to refer to EDS as a hereditary disorder of connective tissue disease. And I don't label anybody as EDS, even though there's a conveyor belt from my office to Dr. DePachi's office, about five people a day, literally, who I look at them when they walk in the room, and I know, without really talking to them, I just look at them and I know that they have EDS, dysautonomia, mast cell activation, and small fiber neuropathy. And this is kind of what I'll focus on. How do I know that? So it was brought up a little bit ago, is it more in males than females? In my estimation, it's 95% females. The makeup of my practice is probably 75% females. And there could be reasons for that that don't have medical implications. Men work, men don't want to go to the doctor, men are proud, men are tough, men are this, men are that. Women, they may have more free time, they go to the gym, they go to the salon, they go to the doctor's office. And maybe I'm wrong, but I'm just speculating that that is a reason. However, if we take a condition like lupus and we say it's female to male 10 to 1, if we take 1 billion people and there's 10 to 1, there's still a ton of people with lupus that are men. So there's really no exception. I mean, there's an exception to every rule. So it almost doesn't matter the fact that I think 90% are females, because there's still going to be a male every now and again. And if I'm not looking properly and I'm not thinking that this person still fits the bill even though we're male, then I'm going to be missing the boat. So how is it clinically that I can look at these people without even talking to them, freak them out because they've been to 4 other rheumatologists, 3 orthopedic surgeons, 2 pain management, 5 cardiologists, 3 pulmonologists, 9 yoga clinics, Pilates, and they've been literally everywhere. They've been to other states, countries, everything. So they walk in the room and the first thing, they're a young female between 15 and 40. They're typically wearing glasses, and the first thing I say is, oh, you're nearsighted. How did you know? And they look at me and I say, well, I didn't ask if you're near or farsighted. I said you're nearsighted. So if you give me a young woman who's nearsighted, the next thing I ask her is, do you bruise easily? Yes, they bruise easily. The next thing, are you on cheerleading or gymnastics? Yes. How do you know all about me? And then they look at their mother, they look at their grandmother. And they're like, this is really freaky. How does this guy know? And they're like, tell me more about myself. Well, you have acid reflux. How did you know? Well, you've either got a hiatal hernia or you have a small fiber neuropathy. What do you mean? Well, if you have a hiatal hernia and your stomach migrates up through the diaphragm, you've got all the acid in your mouth, so you have acid reflux. If you have a small fiber neuropathy, and this goes directly into dysautonomia, these patients, the population of these patients, perhaps 50% of them, they have gastroparesis, delayed gastric emptying, small bowel bacterial overgrowth because the small bowel doesn't push the food through fast enough, and they have colonic inertia or paralysis. Why? Because the nerves that innervate the GI tract are not working. Now, of course, we can have a scleroderma, myositis, or lupus patient who can't swallow because they have muscle weakness, but that's distinct. They have inflamed muscle and is weak, as opposed to somebody who has nerves that aren't working to fire the nerve to the muscle. So the nerve is what you plug into the wall and the electricity comes out of it, and the toaster is the muscle. So the toaster is working fine in these people. They don't have myositis. However, the cord is plugged in and there's no electricity. So if I go from head to toe, and this is what I end up doing, and so I'm going to tell you guys that for every part of the body, there can be a problem. And the hereditary disorders of connective tissue, which is highlighted by EDS, but in my opinion, should be genetically proven. And if there's a suspicion for vascular EDS, which can cause, in the worst case scenario, dissection, aneurysm of the aorta, the subclavian, the vertebral, and then an infarction of the pons. So that's your worst case scenario, short of sudden death. Okay, so the person comes in, and I say, look, we're going to go, and we're going to talk about this hereditary disorder of connective tissue, which in English translates to your body glue, which holds you together, is called collagen, and there's something wrong with your collagen. So your glue, which is collagen, is supposed to keep you sealed together nicely, except it's not. So to try to keep in order with how I do it in the office, just so I don't lose track of where I am, if your eyes are stretchy, because your collagen is not sealed, stretchy eyes, nearsighted. Stretchy skin, you get fragile skin, you get cigarette paper scars, stretchy blood vessels, you get bruising in the arms, you get varicose veins in the legs. Let's see, stretchy ligaments leads to hypermobility. The thumb can touch the wrist, the ankles roll, the kneecaps, the patella, they grind and slide. So people stand up, they have knee pain. The shoulders pop, click, snap. If we get a little more fancy, and these are more rare, if your lungs stretch, you'll have a pneumothorax. If your muscles stretch, you'll have a hernia. If your colon stretches, you'll have diverticular disease. If things are too stretchy and they don't form together in the birthing pathway from embryo, fetus, birth, you'll have spondylolisthesis. The vertebrae don't properly form. You'll have a cleft lip or a cleft palate. You'll have a Chiari malformation. You'll have a syrinx, the dilatation of the inside of the spinal cord. You'll get a tethered spinal cord. You'll have frequent fractures. So that's a global clinical picture of what I see when I look at somebody. Now, because I just mentioned fractures, the reason I don't like to say everyone has EDS is because if somebody has a visible choroid and the white of their eye looks blue or gray, and they have a lot of fractures, and everyone thinks they have EDS, they actually probably have osteogenesis imperfecta, so that's one of the mimics. And then the people who have the chicken skin from here to here, those people who have so-called angioid streaks in the retina, and also have a hypermobility syndrome, they have pseudoxanthoma elasticum. Then you have sensory neuronal hearing loss with cleft palate. That's Stickler syndrome. The list literally can go on all day and all night. There's several hundred. Low-ED syndrome. It literally looks the same as vascular Ehlers-Danlos. There's absolutely no way to tell the difference other than by genetic testing. And the treatment's the same. Hopefully you'll save their life and then keep their blood pressure low. And I want to just touch on something else. It goes to I started by talking about fibromyalgia and how it doesn't, it exists, but nobody actually has it. Everyone has hypermobile dysautonomic. So where does the pain fit in? The pain fits in because of early osteoarthritis, because the joints move too much. They wear out the cartilage at age 30, not at age 40. The other reason they have pain is small fiber neuropathy. My skin is burning everywhere. My whole body hurts. My hair's on fire. Well, if your hair is not on fire and you think it's on fire, it's because the nerves in the skin are swollen and burning, and that is a small fiber neuropathy. Dr. Depachi may be the only one in the country who can do sweat gland testing and diagnose accurately small fiber neuropathy. The other way to do it would be a skin biopsy, which is much more cumbersome, and frankly, 6 dermatologists in the 5 counties of South Jersey down this way have said, do not send me these people. It's not Botox, and it's a little bit of work, and you actually might have to think, so forget that. Let's see, so the pain aspect of these EDS, dysautonomic, mast cell activation, small fiber neuropathy patients, the pain is in the small fiber neuropathy, and the pain is in the hypermobile joints, which cause early osteoarthritis. That being said, 10% of this population of people will have an underlying inflammatory disorder, whether it's lupus, Sjogren's, rheumatoid arthritis, scleroderma, myositis, Crohn's, ulcerative colitis, sarcoidosis, and the list literally goes infinite. We recently had a case of Pompe's disease. We recently published a patient with Fabry disease. All of these people have one thing in common: pain. And it takes somebody to actually talk to them, touch them in all the right places, and find out that the lady that I just saw in the emergency room, who had a cardiac workup for chest pain, no cardiac pain. A week later, she came to the emergency room with kidney stones, but there were no stones. And all I did was I touched her ribs, and I found out that this whole thing was costochondritis. Go figure. So just like everything else is stretchy, so are the costochondral margins. Those are the things that keep the ribs and the sternum all together. Let's see. So I talked a little bit fibromyalgia and why it's not, and EDS and why they could be other names for different phenotypes that we see. Fatigue. So here's another big part of this. Chronic fatigue is an interesting term, and it means different things to different people. When people come in insisting to me that they have chronic fatigue, that is a description that they're giving me. I would prefer they just say, I'm always tired. I don't really care if you think you have a diagnosis of chronic fatigue. However, I do want you to articulate, I'm always tired, I need naps, something to that effect. So the first question I ask these people is, are you depressed? Sometimes they are, sometimes they're not sure, sometimes they're not. If you're depressed, you can have bad sleep, you can have fatigue. If you're having sleep apnea, which many people have undiagnosed, they're going to be fatigued all the time. You take anybody and you deprive them of sleep, you will create fatigue. So if you want to define these things as chronic fatigue, you can be my guest, and maybe you're right, but the term doesn't matter to me. All I care about is why are you tired, and how do I fix it? So sleep apnea, depression, and uncontrolled inflammatory disease. So you give me the same person that comes in double jointed and everything hurts, oh, they're tired. Yep, check for sleep apnea, see if they're depressed, and then consider treating them for an inflammatory disorder and certainly looking for it, and that's where the 10% of people come in that have any number of problems, and I named about 10 of them already. And if I didn't mention psoriatic arthritis, probably is as common as any other. Let's see. So I touched on fibromyalgia. Now I just touched on the chronic fatigue aspect. Is there anything else clinically that makes sense that I didn't mention?
How about autoimmunity?
So autoimmunity,
Connective tissue, what is your stance on that?
so 10% of the people that come who have an obvious EDS variant with dysautonomia, 10% of them do have an autoimmune disease, whether it's RA, lupus, Sjogren's, scleroderma, myositis, Crohn's, psoriasis, ulcerative colitis, ankylosing spondylitis, sarcoid. There's 10 conditions that are all autoimmune in nature that make up the 10% of people, or 12 or 15% of the people that I see. For example, I see people and they come to me for pain. They may have an autoimmune, they may not. I send the people to Dr. DePace, and he diagnoses their small fiber neuropathy and treats them with the antioxidants, the alpha-lipoic acid, and so on. On the flip side, he sees people who he's diagnosed on his own with EDS, dysautonomia, small fiber neuropathy, yet after a year of treatment, or after a certain period of time with treatment, they're still having disabling pain, dysfunctional pain. So they come to me. And he's sending me that jaded population because he can't get them better, and all of those people end up having RA, lupus, Sjogren's, scleroderma, myositis, psoriatic arthritis, Crohn's colitis with arthritis, sarcoid, etc. So I don't know, I don't think it's cause and effect. I think it's kind of like the breast implant issue. Who gets breast implants? Young women. Who gets scleroderma? Young women. Is there a connection between the two? A group in Florida said yes, a group in Pennsylvania said no. But I personally don't think that autoimmunity and the hypermobile, and by the way, people always use the word for lupus. I have a connective tissue disease. No. Autoimmune disease would be lupus and RA and Sjogren's, while connective tissue disease would be EDS, Stickler's, osteogenesis imperfecta. Those are hereditary disorders of connective tissue, and 10% of that group fits over here. This group over here, they have their diagnosis, and oh, by the way, 10% of them happen to have an EDS, or maybe 20% have a, and again, I don't like to use the term EDS, because some of them have OI, Stickler's, pseudoxanthoma, etc. And by the way, we've seen all of them. There's almost none that we haven't seen, and if there is, I just forgot. The spectrum of these diseases is tremendous. Genetic testing is helping to make it a little bit easier because we can actually give it a name sometimes. When in the past, we would just say EDS, dysautonomia, dysautonomia. But literally, I get people looking at me with the dirtiest looks when they first come in, because I tell them in 1 second what's wrong with them. They look at me like I'm completely crazy. And then after explaining it to them, all of a sudden they're so happy because now they understand that if you're looking at it all day long, it's easy to see. I'll be happy to take some questions. And I apologize for no slides. Yes?
You know, I used to get hung up on what's the difference between collagen vascular disease and connective tissue disease.
Collagen vascular disease, to me, is autoimmune problems, such as lupus, and connective tissue disease would be collagen defects, such as EDS.
So one's genetic and one's probably acquired sort of.
Yes, and I think it's just a matter of the nomenclature, and the terminology and nomenclature for various important or non-important reasons evolves and morphs and changes every 5 to 15 years, depending on who is in charge of what committee.
But see, before I started working with you many, many years ago, I used to lump those two entities together, but now I understand the difference.
Yes, I
A
mean,
lot of doctors don't.
so Dr. DePace and I have been collaborating with patients, I would say, for 20 years. And we have, I don't know how many patients we have in common, but we have between 3,000 and 6,000 that have what we're talking about now. And no, we're not just labeling people and trying to build numbers. These are people that are finding us from every city, every state, every country, every continent, because they can't get answers. And when we give them answers and get them better, they tell 500 other people. So we're not making it up. It's out there, it's common. It's, you know what, I sometimes wonder, I was taught, I think as a medical student or something, that mitral valve prolapse was a normal variant. Well, I think mitral valve prolapse is just another collagen defect, and if it has a murmur, it's more serious, and if it doesn't have a murmur, it's less serious if the mitral regurg or not. However, the whole concept of the stretchiness of the collagen makes sense. So if 20, 30, 40% of the population has EDS, then 20, 30, 40% of the population will have mitral valve prolapse. And you know, all these people with varicose veins. No, it's not normal to get varicose veins when you get older. What happens is, and if you never heard it explained this way, I'm going to tell you, the vein is a straw, and so the arteries are a very high pressure system. The heart shoves out the blood real fast under high pressure. The blood goes all around the body, it goes through the capillaries, and it comes back to the veins. I mean, into the veins, back to the heart. Well, how does it get there? There's no heart in your feet. There's a pumping mechanism. Pump, 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 pump. But if you have stretchy veins, the veins will go from this size and they'll dilate. But the valves in the vein, they're like a pinball machine. Except they're supposed to do this and be sealed. Except now the vein is here, so they're going like this. So it pumps up and they come back down. Regurgitation of flow equals varicose vein. So that's where all this vein disease, I mean, I'm sure President Trump has nothing more than regurgitation of flow. Is it his age? Well, as you get older, the veins get a little stretchy. If you play golf and you stand a lot, your veins may have a little more pressure, and that'll lead to dilatation. No different than having a hernia with the muscle stretching. No different than having diverticular disease, having the colon stretching. Anything that's going to stretch a lot. Like if you're constipated all the time, you're probably going to get diverticular disease. But if you have predisposition by having stretchiness of your collagen, which is supposed to hold your colon together, if you don't have that, you're going to dilate faster.
What do you feel about most of these people are coming to the primary asking for pain medications and management of their pain? Like, how would you?
Okay, so the way to treat the pain in these patients is to ascertain a clinical diagnosis. So if the person has hypermobile pain with early osteoarthritis, you treat the osteoarthritis with whatever you pick. Tylenol, topical NSAIDs, joint injections, physical therapy. The best way to help the knee pain and the chondromalacia patelli is an open patella knee wrap and a knee injection, depending on how bad or how much pain and how bad the x-ray looks. And then on the flip side, if the person has pain in that scenario and they're burning all over, they need to go on antioxidants, alpha-lipoic acid, beetroot extract, and all these different things that are helpful. Now, there is a group of people that have immune-mediated small fiber neuropathy. So we have the diabetics, they all have neuropathies. We know the cause, it's diabetes. We have the COVID people, they have COVID-related or viral-stimulated small fiber neuropathy. But then we have all these other people that we have a massive antibody panel, which is when he says, I order more tests than everybody. I now have a person with GAD65 autonomic neuropathy, ganglion acetylcholine 3, blah, blah, blah. They're all treated with IVIG. And it works 85% of the time in 85% of people.
So
And you got to give them a year of treatment.
So I understand there's the treatment of it, but like they will keep coming to the primary asking, well, I tried the NSAIDs, I tried the topical, it's not
They
helping.
need to be referred to a rheumatologist or a neurocardiologist or both, and they need to have a proper evaluation and workup. You can't just say they have pain, give them pain relief. I mean, you can do that at the ER for 5 days, but you got to refer them to the right place so they can get a proper diagnosis. Without a proper diagnosis, nobody's going to get better. You're going to run out of Band-Aids if you don't refer them because they'll never get diagnosed. And we recognize this because this is all I'm not going to say it's all we do, but it's something we do on a regular basis for, between the two of us, there's almost 75, 80 years of practice. You know, it's a lot of stuff.
Does it affect your immunity? Are you?
No. If you have an immune problem, you may have a problem from that. Having one of these diseases does not affect your immunity, it's the opposite.
Oh,
Yes?
Is there any change in the C-reactive protein on this group of patients?
No. This is not an inflammatory condition. If you have an elevated CRP, we're going to presume that the patient is suffering from some form of inflammation. And if you have a pure connective tissue, hereditary disorder of connective tissue, EDS or EDS variety, that person should have completely normal blood. Nothing should be abnormal, absolutely nothing.
is there any nutritional supplements that like people will say?
There are, and that is 100% Dr. DePaci's wheelhouse, and I won't comment on it because whatever I say is subject to being overridden by Dr. DePaci. Okay, I guess there's no other questions.